Hello guys, uh, I hope you got my message earlier that we're going to start at 6 at 18. So right now I see more people are joining, which is good. I apologize for being late, but as always, Fridays are expected to be less busy, and then something else happens, like 2 myocardial infarctions at once, or something like this that happened today. But yeah, everything is all right now. I think we can wait a little bit more if anyone else is going to join. Maybe 2 to 3 minutes. Did you start your other subjects? I guess you're already in Bulgaria and you're going to other exercises. Yes. Okay, that's good. I told you about the final exam last time, right? That it's going to be on the 24th and 5th, the first 4 groups on the 24th and on the 25th, the last 4 groups. We haven't decided about the questions yet, but when there is a decision, I will inform you about this decision. I think we can at least start talking about today's topic, which is not going to be very long. It's Friday afternoon, even Friday evening, so I'm not going to be holding you up for too long. So yeah, it's 2 minutes past 18, so I think we can start. Okay. Just give me a moment. Okay, now I think you can see the presentation. So today we're going to talk about rational drug therapy in liver failure and in hepatitis, which is also one reason for liver failure or liver cirrhosis. In chronic liver failure, I don't even have to tell you that the main thing that happens to the liver is called cirrhosis, and we're going to see what kind of therapies we have in cases of cirrhosis. First, let's talk about the different types of liver failure in terms of the time period of development of end-stage liver failure. If we have an onset of symptoms due to liver failure within 10 days of liver injury, so let's say today a patient takes too much paracetamol, let's say, or contacts hepatitis virus and develops symptoms of liver failure within 10 days of today. So let's say next week, we call this hyperacute liver failure. So this happens very fast. This is also one reason for acute liver failure due to fulminant hepatitis. So fulminant means very fast, like a thunderstorm. Acute liver failure is liver failure that develops between 10 to 30 days after liver injury, and coagulopathy is something that is very characteristic of liver failure, especially of end-stage liver failure. When it is chronic, we get a high INR. So INR, if you remember correctly, is the international normalized ratio, and it is usually between 0.8 to 1.1 or 1.2 in healthy people. And if it's hard to remember, you can just remember that the INR usually should be 1 exactly. So it's a ratio, it doesn't have any units. But when patients start taking anticoagulants like vitamin K antagonists, warfarin or acetylcumarol, which are some widely available vitamin K antagonists, the INR starts going up. And usually in atrial fibrillation, our goal is for the INR to be between 2 and 3. When we have patients with mechanical heart valves, usually we aim for the INR to be between 2.5 and 3.5. But in patients with liver failure, even though they are not taking vitamin K antagonists, they start getting high levels of INR, which also increases their risk of bleeding, but it is not as the risk of bleeding that is due to the vitamin K antagonists. And the levels of INR is something that we follow in these patients. And if it's too high, if the INR is very high, which means above, let's say, 2.5, above 3, it's a very bad prognostic sign. If the INR is normal, if it's less than 1.3, let's say, it's a good prognostic sign. It means that the liver failure is not yet decompensated. The next type of liver failure is subacute liver failure, and this is when coagulopathy. So by coagulopathy, we usually mean this increase in the international normalized ratio, or INR, develops between 1 month to 6 months. And in this case of subacute liver failure, usually jaundice is almost always present. We can have patients with some degree of encephalopathy, which is also a bad prognostic sign. And some examples of conditions that lead to subacute liver failure are, for example, Wilson disease. Autoimmune liver diseases like autoimmune hepatitis can be one such example. And also some drugs can cause subacute liver failure, like paracetamol is one such drug, but paracetamol usually causes liver failure that is acute, not subacute. And the last type of liver failure that we can mention is chronic liver failure, which is a liver failure that develops usually 6 months after the onset of hepatic illness. And in this case, we usually have signs of hepatic encephalopathy, which again, we said is a bad prognostic sign for the survival of this patient. In chronic liver failure, we mentioned that cirrhosis is the defining characteristic, and the defining characteristic of cirrhosis itself is hepatic fibrosis. So, in your classes in pathology, I am sure you saw some macroscopic liver cirrhosis preparations, and this liver looks usually smaller than the normal liver, and it has a very characteristic fibrotic tissue and fibrotic appearance, with also deformation in the normal hepatic architecture with the formation of regenerative nodules. So if you look at the nodules under a microscope, you're going to see that they have a structure that is similar to a normal functioning liver, but around these normal islands of liver tissue, we have a massive fibrotic tissue, and this actually gives the macroscopic appearance of this fibrotic liver. And this is very typical of cirrhosis. Another thing that happens is that we have a decrease in hepatocellular mass in the liver. This is something expected, something that is expected to happen due to the fibrosis. Also, we have a decrease in function, and we have an alteration of blood flow, which means that we will have some issue with the formation of new blood vessels, and also the dilation of some blood vessels, like those in the abdomen. If you have seen patients with end-stage liver failure, you know what I'm talking about. This is actually called caput medusae. When this happens on the abdomen, we have a dilation of the veins, and this is due to the increase in the portal system, increase in the pressure of the portal system, or this condition is also called portal hypertension. Portal hypertension also leads to the formation of varices in the esophagus, and these varices we call esophageal varices, and they usually bleed. And this is one of the reasons that these patients die. So they bleed from the varices in the esophagus, and they die due to hemorrhagic shock if they're not ligated and if the bleeding is not stopped in a timely manner. Clinically, we classify chronic liver failure as either compensated when the patient is feeling well, almost asymptomatic, and when the patient's symptoms get worse, this is a state of decompensated liver failure. The etiology of liver failure is different. As you can see here, we can have infection with different HIV, with different hepatitis viruses. The main thing, the common thing about hepatitis viruses are that they injure the liver. That's why they're called hepatitis viruses, not that they are in structural similarity with each other, because as you know, HBV or hepatitis B virus is a DNA virus actually, and HCV and HAV viruses, or hepatitis C and hepatitis A viruses, they are RNA viruses. And this again shows you that the main site of injury is the thing that connects the hepatitis viruses, not their structure, not their taxonomic classification. Alcohol is another reason for liver failure. This usually causes First, alcoholic steatosis, then alcoholic steatohepatitis, and then alcoholic cirrhosis. This is actually something that is reversible, but very hard to achieve in some people, especially who don't have enough motivation to stop drinking alcohol, and this leads to, of course, to negative consequences regarding their health. Autoimmune causes like autoimmune hepatitis, cholestatic liver disease. This means not only, but this can mean gallstones also. So chronic cholecystitis is also another reason. Also primary sclerosing cholangitis or PSB or PSC is another reason. And also we can have infiltrative causes, metabolic causes, vascular, and of course drugs that are hepatotoxic. What are the complications of liver failure? Ascites, of course, I'm sure you've seen patients with ascites. They're usually not very fat. They have thin legs, thin extremities, upper and lower, but around the abdomen, they look fat. Actually, this is due to the ascites or the fluid in the abdominal cavity. GI bleeds are common due to variceal bleedings, which are also helped by the INR levels if they're high. Spontaneous bacterial peritonitis is something also that should be feared in such patients. Edema, which is related to ascites, hepatoma, encephalopathy, and hepatorenal syndrome. The child Pew score is actually a very useful score to calculate in order to get an idea about the survival of the patient. So if the patient is classified as class A, the survival after 1 year of diagnosis of chronic liver failure is usually 100%. If it's class B, then the survival is around 80%, and in class C, it's less than 50%. So you can have a look here at the different criteria that are included in calculating the Child-Pugh score. And here you can see that we use total bilirubin. You should take care about the units that are used, because in different countries, different units are used. There is a very nice website called MD Calc, where you have free access to different scores, different classifications, and you can just write Child-Pugh score MD Calc, and you can go there and calculate the Child-Pugh score of a patient. Of course, if you have the information about their bilirubin, albumin, INR levels, and of course, ascites is something that you can examine, and you can put the diagnosis clinically, or by using an echo or another imaging method like CT scans and hepatic encephalopathy also. What are the non-pharmacological treatment options of liver failure? Of course, we start with dietary modifications by increasing the protein intake. So in cases of liver failure, patients lose protein, and that's why their intake should be increased, not decreased. Enough exercise, and we also have surgical methods of intervention. But the definitive actually intervention and the definitive therapy is actually getting liver transplantation. However, this is not something that is very easy. In some countries, there is a very long waiting list, including Bulgaria. So it's not something that is easily achievable, unfortunately. Pharmacological options, we have weight-losing agents like orlistat, if you remember from third year, insulin sensitizers like metformin is the main insulin sensitizer, not so much thiazolidine diones. They are rarely used. Antifibrotic and hepatoprotective agents in this place. In the first place, we should mention deoxycholic acid. This is the so-called ursofalk, which is the trade name of this. Actually, this is a bile acid, which is found in the bile, and this helps the breakdown of cholesterol. And if patients have a cholesterol bile stone, this drug helps breaking down the cholesterol bile stones. The next slide is about alcoholic liver disease that we mentioned. First, it is usually as steatosis, then it develops into hepatitis, and then into cirrhosis. If you have a patient with alcoholic liver disease, of course, the first thing that the patient needs to do is abstinence from alcohol, which is again not very easy to achieve. Patient may need treatment with drugs that will help withdrawal symptoms, like baclofen, increased protein intake, fluids and electrolytes are very important, like magnesium, vitamins, potassium levels are important to follow up. And if the patient has withdrawal symptoms, then you may have to use some benzodiazepines to just calm down the patient, to get benzodiazepines as anxiolytics, actually, like diazepam or lorazepam. Management of complications. We're going to see what complications these patients can get. Now, a few words about the viral hepatitis. Usually, it's hepatitis B or hepatitis C when we are talking about chronic liver disease, because you know that hepatitis A does not lead to cirrhosis. But hepatitis B and C, they lead to cirrhosis, and also they increase the risk of hepatocellular cancer. In hepatitis B, usually we use nucleoside analogs like lamivudine, adafovir, and entecavir, and these drugs are used also in the treatment of HIV virus in AIDS patients. The good thing about hepatitis B is actually that there is a vaccine which is pretty effective, and usually in most countries the hepatitis B vaccine is one of the first vaccines to be administered to a newborn child, usually within 72 hours after delivery. So you are probably all vaccinated against hepatitis B, but if there are people who are not vaccinated, it's a very good idea to get vaccinated, because the medical profession is probably the riskiest profession of getting hepatitis B virus and other bloodborne infections. Hepatitis C has been big problem, let's say. It used to cause a lot of trouble because there is no vaccine against hepatitis C, unlike the hepatitis B virus. And the drugs that were available, like interferon and ribavirin, they were not very effective, and also they caused some serious adverse drug reactions, including psychiatric illnesses, also renal toxicity, hepatic toxicity. But during the last couple of years, literally, like this happened around 2015, 2016, so 5, 6 years ago, almost in every country there is access to novel therapies, and we're going to see what are these novel therapies in a little bit. And this actually solved the problem with hepatitis C to a great extent, and hopefully this will be the case also with viruses like HIV or COVID-19 or any other virus. Because the thing that was achieved with the therapy of hepatitis C is actually quite remarkable. Now I would like to show you two slides about the different serologies that you can observe in hepatitis B virus patients. And here you can see according to whether they have, so AB means antibody, AG means antigen, and S means surface. So this is the hepatitis B virus surface antigen. This is hepatitis B virus surface antibody. So the antibody that was formed against the surface antigen. So this is antibody, this is antigen. And C means core. So this is the core antigen. There is a core antigen that is found in the hepatitis B virus. But as you can see here, it is AB. So this is the antibody that was formed against the core antigen. And according to this table here, you can just send the blood of a patient to the laboratory and look at the results. And according to these results, whether the patient has antibodies against the core antigen or against the surface antigen, you can determine whether the patient has been immunized, and that's why the patient has antibodies, or whether the patient had been exposed to the virus, and that's why has antibodies. Because the vaccine against hepatitis B is only with surface antigen and doesn't include the core antigen, usually patients who are vaccinated, and that's why they have antibodies, they have only the antibody against the surface antigen, but those who have been exposed to the virus, they have both the surface antigen antibody and the core antigen antibody. So this is something that is useful if you are a gastroenterologist or an infectious disease specialist. This again is the same table with a different different classification and different format of the table. This is the serology of the HCV patient. It's a lot easier to interpret. First, we have the HCV virus RNA, which is the sign that the HCV virus is an RNA virus. Then we have the HCV antigen, and it usually starts going down after a couple of months. And then if the patient develops a chronic hepatic failure, he will usually have also anti-HCV antibodies. What are some drugs that are used in autoimmune hepatitis? Of course, immunosuppressive drugs because it's an autoimmune disease, like prednisolone, methylprednisolone, other corticosteroids, azathioprine, newer drugs like cyclosporin, tacrolimus, which are also used after liver transplantation, mTOR inhibitors like sirolimus, everolimus, mycophenolate mofetil, which is also an immunosuppressive drug. In non-alcoholic fatty liver disease, usually patients are with metabolic syndrome, they're overweight, and one of the first things that they need to do is to lose weight. Also, metformin should be used if they have metabolic syndrome. Bariatric surgery is also an option if they're too much overweight. In complications of cirrhosis from portal hypertension, we get patients with variceal hemorrhages, ascites, which can lead to spontaneous bacterial peritonitis, hepatorenal syndrome, encephalopathy, jaundice, and also bleeding from the varices that we said if not stopped on a timely manner, these patients usually die of hemorrhagic shock. Here you see varix that is not bleeding, but here you see what a bleeding varix looks like, and this is done by endoscopy. The management of varices, if there is no bleeding, depends on the size. If they're too big, they're usually ligated. If there is bleeding, uh, the ligation should be immediately done. But also, we use beta blockers in terms of the chronic treatment of non-bleeding varices, like propranolol. And propranolol is a non-selective beta blocker, which is with a shorter half-life. That's why it needs to be taken 3 times a day, usually 20 milligrams each time. We talked about the bleeding, and when there is acute bleeding, we need to also control the hemoglobin level. If it's above 8 grams per deciliter or 80 milligrams per liter, then there is no need to do a hemotransfusion. But if it's less than 80, then hemotransfusion is warranted. Uncomplicated ascites. In patients with ascites, we need to follow the electrolyte levels and also use diuretics, mostly spironolactone, which is a potassium-sparing diuretic, but also furosemide, which is a loop diuretic. If you remember, we use spironolactone and furosemide also in heart failure patients, but at different doses. Usually in liver failure, the dose of spironolactone is a lot higher. In heart failure, it's from 25 to 100 milligrams a day usually, but in ascites, we use higher doses from 100 to 400 milligrams a day. Furosemide from 40 to 160 milligrams a day, which means from 1 tablet, which is 40 milligrams, to 4 tablets a day, which is also a dose that is comparable to the dose that we use in heart failure. There are also diuretic intractable ascites and diuretic resistant ascites, in which case there is no clear effect positive effect, even though we have reached the maximum diuretic therapy. Then we need to think about doing a invasive procedure of getting the ascites out of the abdominal cavity by using a needle. If spontaneous bacterial peritonitis happens, the treatment is of course by using antibiotics. Usually this is cephalosporin antibiotics or other beta-lactam antibiotics like cefotaxime, amoxicillin, clavulanic acid is another option. Usually the treatment lasts 7 to 10 days. The management of hepatorenal syndrome is something that is not well established. One thing we know is that dopamine and prostaglandins are not very effective, unlike in other cases of renal failure, when dopamine at the so-called renal doses is effective, but not in case of hepatorenal syndrome. Also, hemodialysis is not very effective. The only problem we see is actually liver transplantation if the patient is not getting better. Treatment of hepatic encephalopathy, lactulose is used in order for the patient to have at least 2 to 3 bowel movements a day. This is in order to get rid of the pre-renal azotemia. And again, liver transplantation is the only definitive therapy. Now, let's talk about chronic hepatitis C treatment. As we said, it's an RNA virus, which is similar to dengue, West Nile, and yellow fever and Zika viruses. There are several different genotypes of hepatitis C virus, but the 6 major genotypes are from 1 to 6, and they have more than 15 subtypes, which is very important to test before starting therapy, because we base the therapy according to the genotype. Here you can see the distribution of the hepatitis C genotypes. 80% of people who are exposed to HCV virus, they get chronic infection, and around 20% they get spontaneous resolution, which is the better option, of course. Of those who get chronic infection, around 20% develop cirrhosis within 20 years, and 1 to 4% of them develop liver failure and hepatocellular carcinoma per year, which is not a small number. These are some numbers that come from the US. So you see that in the 80s, when also HIV virus was discovered, and there was a epidemic of HIV virus, because the hepatitis C viruses is also transmitted either by hemotransfusion or sexually. The two viruses, HCV and HIV, they also went together. So after the information campaigns and after people started knowing more about the viruses, you see that these numbers went down, but recently there is also an increase in the number of people with HCV. These are the data about hepatitis C virus. So it can be transmitted either by exposure to blood, vertically from mother to infant during childbirth, or sexually. And the risk factors for hepatitis C, these are data from the US. You can see them. What do we do in terms of therapy? Well, we use drug combinations that are non-structural protein inhibitors, and these are usually combination of leadipasvir and sofosbuvir, for example. And these are the trade names here. Harvoni is one of the more popular ones. Viekira is another such drug, which again is a combination drug with ombitasvir and paritaprevir, which are again NS or non-structural proteins inhibitors. But again, we need to have genotyping before starting therapy. The good thing about therapy is that it's not very long, so it usually takes 2 to 3 months, but it is very, very effective. So you can see that the leadipasvir is a non-structural protein 5A inhibitor, and sofosbuvir inhibits non-structural protein 5B. Here you can see the mechanism of action of these two drugs against the hepatitis C virus. You can see that here the RNA replication is stopped due to the action of sofosbuvir and leadipasvir. And these are data from the clinical trials, and you can see that the efficacy is above 95%, so it's close to 100%, which is a huge number. And these are not just preliminary data, these data are also confirmed clinically. So if you get vaccinated against HPV, nowadays we can say that you are pretty much protected against developing chronic hepatitis, because for hepatitis B there is a vaccine, and for hepatitis C there are very, very effective drugs. And that's it for today. Again, sorry for being late, but unexpected things happen sometimes. If you have questions, you can ask your questions now. If not, I wish you a nice weekend, and I hope to see you next week at 5 p.m. If something comes up, I'll try to inform you a little bit earlier. Yep. I don't see any questions. So see you guys next week. Bye-bye.
You are currently the only person in this conference.